Hi everyone. We're going to get started with the Bionano showcase presentation. I'm Alex Hasty from Bionano. I'm going to give a quick introduction of our speaker. It's really my pleasure to introduce Phillip Michaels. He's a hemato-oncologist and molecular genetic pathologist and the medical director of the CAMD Translational Biomarker Core at Mass General Brigham and Harvard. And he's going to talk to us about the status of a multi-site clinical study that has been ongoing with a lot of participants, some of whom are in the audience here today. It's my real pleasure to listen to Philip's presentation. I'd like to welcome Philip to the stage. Thank you.
All right, good afternoon, everyone. As Alex mentioned, I'm Dr. Phillip Michaels. I'm a hematopathologist, molecular genetic pathologist. I do clinical duties as well as some administrative and research roles. I'm also the medical director for a translational biomarker core, which is a CLIA-certified molecular laboratory. So today I'll be talking about improving sensitivity and workflow efficiency in myeloid malignancy research with optical genome mapping, which is a multi-institutional study. Just a brief kind of introduction and outline of the talk. I'll be stating the scope and aims of the study, which is a multi-site, multi-operator, multi-director hematologic malignancy study by optical genome mapping. Real brief workflow overview of hematologic malignancies being assessed by optical genome mapping and their standardization process. And that's going to be the real heart of the matter, is the guideline and tiering improvement that you typically or will be seeing in OGM in the future, and the coordination that took place with multi-institutional PIs. I'll be briefly discussing the AML cohort that we have, which demonstrates concordance and diagnostic yield in relation to standard of care or conventional cytogenetic assays, with some few case studies, and then I'll really hammer home the turnaround time and cost effectiveness of OGM compared to standard of care assessment. And then just a brief conclusion of what our study found. So the study goals and aims of this particular multi-institutional study was at multiple sites across the nation with multiple operators and multiple instrumentation or multiple instruments at each site. Concordance was assessed with a standard of care testing, which included cytogenetic or conventional karyotype and FISH analysis. And we wanted to demonstrate that there's potential diagnostic, prognostic, and treatment implications that may be relevantly found by OGM. This is a retrospective analysis with the look forward to do a prospective analysis. And the two main kind of aims or endpoints was the turnaround time and cost effectiveness of this platform when compared to conventional karyotyping, FISH, and chromosomal microarray. Here are the clinical trial sites across the nation. Of course, as mentioned, I'm at Brigham and Women's Hospital in Boston, Massachusetts, and my collaborator there is Scott Ryall, and these are the multiple collaborators we have across the nation. So, as many of you are aware of for optical genome mapping, it kind of bridges the gap between what may detect single nucleotide variants and small insertions and deletions to larger whole chromosomal or whole arm genomic aberrations. So with short read sequencing, which is the traditional targeted NGS panels we're all used to, both clinically and research, to those of long read sequencing, which has become the next iteration of sequencing platforms, to those that are more conventional and run on almost all hematologic malignancies, including fluorescence in situ hybridization, chromosomal microarray, which is really good for copy number analysis if you have enough tumor cells, and then conventional karyotyping. So as you can see in this graphic, there's actually quite a bit of a chasm between large chromosomal aberrations and those of smaller single nucleotide variants and small indels. And this is where OGM can kind of bridge that chasm, ranging from down to 500 base pairs up to a whole chromosomal changes. And OGM is just basically, practically cytogenetics with a much higher resolution than your typical karyotype. And it's fully automated, very little hands-on time when compared to standard of care conventional karyotyping and FISH. Doesn't require a tremendous amount of labor or tech time. It's genome-wide analysis. It gives you exact chromosomal position and the genomic coordinates with single molecule resolution, which is actually kind of represented on the left-hand side. So it's a platform that offers really high resolution with a shorter turnaround time. So this is kind of like just the basic underpinnings of what OGM is, especially for structural variants. You take your sample, which is either blood, bone marrow, or cell pellet, or cancer cells. You isolate the ultra-high molecular weight DNA, fluorescently label it, and it's linearized in these nanochannel arrays. And then this is where the optical component comes in, where it's imaged as single molecules, digitized, and then mapped to the human genome, which will then reveal their structural variants, translocations, fusions, copy number changes, stuff like that. So kind of going from the underpinnings of what OGM is, one of the issues we were having, and this is something that probably plagues all instrumentation, all platforms, whether it's NGS, karyotype, FISH, is what are the kind of the diagnostic criteria that you're utilizing for assessing these disorders? And fortunately, there's the three guidelines we utilized in our study, which is the NCCN, WHO, and NHS guidelines that spell out specific genomic aberrations that should be either tested for or highly assessed for, irrespective of the platform. So as illustrated here, these are the ones that would be considered diagnostic, prognostic, even have therapeutic implications. So we were trying to capture that and then go into a tiering system. I'm sure for those that do NGS are well aware of the tiering system outlined for pathogenic variants or benign variants. We were trying to kind of capture that kind of mindset with assessing genomic aberrations by OGM. Tier 1A is typically considered, or is considered, those that are pathogenic and diagnostic, whether it be in the WHO or ICC classification for hematologic malignancies, has therapeutic implications and significant prognostic implications. Tier 1B and Tier 2 kind of get into a little bit more of a nebulous area, and this is where it comes in the context of Tier 1B, meaning like it's fairly specific to a disease, but it confers some prognostic evidence, but it's unclear if that changes therapy for the patient. Whereas Tier 2 is considered pathogenic, but it's unsure if it's going to change the outcome. So, and also just to note that genomic complexity is assigned with 3 or more large chromosomal aberrations where they're larger than 5 megabases. So with that being said, there was 10 samples analyzed by 5 to 6 sites with the standardized VIA workflow, which is our interface. 4 were negative AML cases, or 4 were negative cases, and 6 were AML cases with reportable findings by conventional karyotype. And OGM and standard cytogenetics identified these variants, and using the WHO, NHS, and NCCN guidelines, 5 of these variants were unanimously tiered 1A, meaning they're diagnostic, have significant prognostic evidence, and are targetable by modern therapies. However, there is variability between reporting Tier 1B, Tier 2, and Tier 3 among the groups. And I think there was a little bit of confusion over that. So with that being said, we move forward to taking 172 well-characterized variants across 7 hematologic malignancy subtypes. So overall, 1,204 classifications to consider. And from 20 investigators across 14 US sites, we added comments to where we think this should belong in terms of Tier 1B or Tier 2 with PubMed or LitSearch evidence. And they were originally, the 172 variants were classified from Tier 2 and broken down into Tier 2 and Tier 1B with sufficient evidence. And this is an overall large study cohort. So moving to OGM and being able to kind of increase diagnostic yield, 98% of those genomic findings were detected by FISH and karyotype were also detected by OGM, so highly concordant among conventional cytogenetic methods. And as you can see here in this graphic, the concordance was actually quite high, and actually about half of the cases for karyotype were, due to the high resolution OGM, revealed more refined nomenclature that the cytobands could not readily identify. And it was highly concordant among karyotype and FISH. Those that were excluded were those that were either non-clonal, meaning in 1 metaphase of the 20 analyzed metaphase, or below the lower limit of detection for OGM. And as you can see here, 117 of 120 variants were concordant, which is highly concordant. So the reason I point that out is because actually OGM found additional genomic aberrations or chromosomal changes that would be classified as Tier 1 or Tier 2, something that's actually prognostically significant, has some therapeutic implications, or is even diagnostic. So a number of cases with new Tier 1 or Tier 2 variants or had copy number loss heterozygosity, which you cannot assess by karyotype or FISH, was actually 67% of 54 AML cases. 26 were negative by standard cytogenetic methods, and 28 had abnormal karyotype or abnormal standard cytogenetics. And then a number of cases that were positive standard cytogenetics but had added resolution, changing the interpretation of the variant by OGM, was about a third of cases, so not insignificant. And those that were completely negative by FISH and karyotype but had a tier 1 or tier 2 identification or aberration with OGM was about half of cases. So not insignificant to show that OGM can further resolve and further identify aberrations in the chromosome. So just kind of moving to some kind of cases that really illustrate these points is this first case is a 57-year-old female with the clinical indication of acute myeloid leukemia. And the karyotype revealed a normal karyotype in 19 metaphases and 1 non-clonal event and 1 metaphase. FISH was all negative over these multiple probes, with 7 fish probes, which is actually quite expensive, the karyotype not being insignificant in terms of cost as well. And most notable, the PML-RARA dual fusion probe set was negative, as well as the RARA breakapart probe set was negative. However, by OGM, there was a cryptic insertion of RARA into PML, which is actually a rare phenomenon but has been documented in whole genome sequencing data. So this is actually could potentially lead to therapeutic and diagnostic implications for this patient had this been discovered earlier on. So there is a potential, there is a cryptic insertion in of PML of RARA into PML, as illustrated here. And this is considered a tier 1A as it is a disease-defining category. The next case actually kind of further gives some clinical relevance in terms there is a copy number loss, a heterozygosity, in chromosome 13 where FLT3 resides. And then this particular patient had a FLT3 internal tandem duplication. So as some of you that are aware, there is the allelic ratio that is used for FLT3 ITD, which has not only prognostic significance, but also therapeutic significance. So this patient actually had a normal karyotype, and NGS revealed a FLT3 ITD and mutations on DNT3A and SMC3, which is part of the cohesin complex. Karyotype, again, was normal and costs, both labor and time and tech time and platform. 5 FISH probes were used, and they were all negative. And OGM is ran and showed the copy number loss of heterozygosity on chromosome 13. With the known FLT3 ITD, you can surmise the allelic ratio is quite high in this patient, which confers a more aggressive clinical course, but also a more sensitivity to a TKI or a FLT3 inhibitor. And this was orthogonally confirmed by chromosomal microarray or oligosNP array. For case number 3, this is a 26-year-old female with a presumed diagnosis of AML. No circulating blasts were identified in the peripheral blood, but the sample was sent due to the clinical concern. Karyotype, once again, was normal, and FISH was performed, which was negative for PML-RARA, KMT2A rearrangements, CB, FB rearrangements, or RUNX1 or RUNX1T1 fusions. As once again, 4 FISH probes were utilized, karyotype being laborious and rather time-consuming and challenging, and OGM was performed. In this case, there was a 89 kilobase pair insertion, which actually formed a KMT2A fusion with MLL-T10, which is a well-characterized, although rare, fusion event, and actually defines a category AML in the new WHO and the ICC with AML with a KMT2A rearrangement, and it's required for diagnosis. Cases with this are actually a little bit more aggressive, but there are clinical trials where they can be enrolled and treated with menin inhibitors as well as their traditional chemotherapy. And lastly, this is a male with the presumption of presumed diagnosis of AML, and a bone marrow aspirate was performed. Once again, karyotype normal, FISH negative. In this case, there were tier 1A and tier 2 findings missed by conventional cytogenetics. In this case, a KMT2A partial tandem duplication was identified. It was actually a triplication, which is a rare phenomenon but documented. And these patients actually, if you look at whole transcriptome data, they cluster to those with KMT2A rearrangements and are potentially treatable with menin inhibitors. So overall, I just wanted to illustrate that the OGM turnaround time is actually quite a bit shorter than concurrent karyotype and FISH. Karyotype can be done as fast as 2 days, we all know that, but can take oftentimes the better part of a week, and that's if it's a more simple or non-complex karyotype. FISH, depending on your probe strategy and depending on its reflexive testing, can take anywhere from a day or 2 to the whole week, and if it's a really complex case and you're hunting for something, it may even take 2 weeks. So OGM, from start to finish, takes approximately 3 to 4 days, from starting assessment of the sample to that of review and reporting. And these are the kind of the assumed estimates at our institution at Brigham and Women's Hospital. OGM costs about $520, whereas karyotype is $810, and depending on your probe set and your strategy, about $400, $480 per probe set. And this does not include the instrumentation that's involved, like whole slide scanners, fish microscopes, stuff like that. So, just in conclusion, OGM detected at least 98% of variants from classical cytogenetics. Actually detected almost half of those cases, half of the negative cases had additional findings, or those that did not show those findings, half had something additional that could change diagnosis. Turnaround times around 4 days, which can be significantly faster than those of the complex karyotypes or those with multiple fish probes employed. And it's quite cost effective. It's less than karyotype and definitely less than using karyotype plus 5, 6, 7 fish probe sets. So the kind of the crux of the matter is we're actually trying to enable better standardization and reporting from OGM perspective, something that plagued NGS early in the days. There's no concordance or standardization or harmonization, as well as being able to increase turnaround time and cost effectiveness. I want to acknowledge the many collaborators that we have. And with that, I thank you for listening, and if you have any questions, please feel free to ask. And we're out of time.